Hi, my name is Shaunak Navalkissoor. I'm a consultant nuclear medicine physician based at the Royal Free Hospital and work in a large neuroendocrine tumor unit. Today, my talk is going to be on DOTApeptide imaging in the multi-staging imaging of neuroendocrine tumors. These are my declarations. So this is the outline of my talk. There's 4 areas that I'm going to be covering. I'm going to be looking at somatostatin receptor imaging in general and the comparison between SPECT and PET agents. And then the main crux of my talk will be on the current evidence-based indication for gallium DOTA somatostatin receptor PET. And next, I'll be talking about pitfalls in gallium-68 DOTA PET. And lastly, on combined molecular imaging using gallium dotatate or DOTApeptide PET and FDG PET-CT to look at the advantages of this. So what is somatostatin receptor scintigraphy? If you can imagine that this is a neuroendocrine tumor cell, you can see that they have a high expression of somatostatin receptors on their surface, at least the well-differentiated type tend to have, and this can be exploited for imaging using radiolabeled somatostatin analogs, which bind to the somatostatin receptors with high affinity. They become internalized by a receptor-mediated endocytosis process, and then become absorbed into the cell and give off, when the radiopharmaceutical gives off a gamma ray, this can be imaged on nuclear medicine gamma cameras or PET cameras. So these are the somatostatin receptor agents that are available for imaging. We have, these are ones that are currently on the market. We've got the PET agents with the gallium dotatate or DOTA-octreotide, the NetSpot, gallium-68 DOTA-octreotide, which is the SomaKit, and we have the SPECT agents, the indium-based octreotide or Octrescan, which is one of the oldest tracers that's been available for a long time, and the newer technetium Hynic-Toc tetrotide or Hynic-Tate, all of which are available for somatostatin receptor imaging. So these are the main agents available currently. So there is no doubt there are some advantages for gallium-68 peptides over SPECT peptides, but the availability of gallium-68 peptides is not optimal around the country, around the UK. So SPECT somatostatin receptor scintigraphy can be used as a surrogate in a lot of patients for selection for PRRT in particular. And SPECT-based traces are positive in greater than 80% of patients with the lower grade tumors, so G1 tumors or lower grade G2 tumors with a Chi67 index of less than 10%. So this is some comparison data of gallium-68 dotatate versus SPECT traces. So you can see in this study of technetium Hynic-Toc versus gallium-68 dotatate, there was superiority with gallium-68 dotatate, particularly in identifying lymph node and bony metastasis, and importantly, there was a change in management in 34% of patients. So similarly, gallium-68 DOTA-TOC versus indium octreotide, you can see the accuracy of the PET tracer was much greater than that of the SPECT tracer, and as well as the normal contrast enhanced CT. And this is one of our patients. This is an example many years ago now, when we are still using indium octreotide, as well as gallium-68 dotatate. And this patient had a mid-gut neuroendocrine tumor with multifocal liver metastases. And you can see the liver metastases are not positive on the octreotide scan, but are intensely avid on the gallium-68 dotatate scan. Okay, so moving on to when to use somatostatin receptor gallium DOTA PET. So the SNM published some guidelines on the appropriateness criteria for somatostatin receptor PET, which I think is quite helpful. And basically, they can be divided into 4 areas. So more accurately, staging, so restaging, identify the tumor primary, and assess for suitability for cold or ready labeled analogs. So firstly, in terms of accurate staging, this is for initial staging after histological diagnosis. If a patient is being planned for surgery, you want accurate staging to identify sites of disease so you can more accurately plan surgery. If a patient has a mass which is suggestive of a neuroendocrine tumor, for example, a mesenteric mass that's calcified with desmoplastic reaction, but this mass is not easily amenable to biopsy, you can use somatostatin receptor PET as a surrogate for the diagnosis. If there's biochemical and symptoms of neuroendocrine tumor, but negative cross-sectional imaging, that's another use of somatostatin receptor PET. So those are the main appropriateness criteria for staging of PET. In terms of restaging, in patients who've got disease that is predominantly seen on previous PET and not seen in cross-sectional imaging, then a repeat of gallium PET would be helpful to identify the primary and unknown primary. About 50% of patients can be identified on PET. And lastly, and probably most importantly, is to determine the somatostatin receptor status. So patients can be treated with somatostatin analogs or treated with peptide receptor radionuclide therapy. So this is a large study performed in the UK at the UCL and the Royal Free Neuroendocrine Tumor Unit. And this looked at the accuracy of gallium-68 dotatate in 1,258 studies, and they found excellent sensitivity and specificity for well-differentiated nets of greater than 90% in all neuroendocrine tumors, highest of which was in mid-gut neuroendocrine tumors. And most importantly, there was a high change in management of 40%, which is a large change in management in these 1,258 studies. So this is an example of one of our patients that we used gallium dotatate PET-CT, and you can see that this patient has a solitary bone metastasis that was not identified on other imaging, is occult on CT, but is intensely avid on the gallium dotatate PET-CT, which changes this patient's management. Another example of a patient with multifocal bone metastases that are occult on CT, and you can see intensely avid on gallium dotatate PET-CT. The reason that they are occult on CT is a lot of these metastases can be bone marrow based and thus missed on cross-section imaging, as they don't elicit a CT reaction in the early stages of the metastases. So restaging. So generally restaging is performed using cross-sectional imaging with CT or MRI, but there are some advantages of using gallium-based somatostatin receptor PET. These are for bone marrow metastases, which are not very well seen on CT. For peritoneal disease, which can easily be missed, particularly small peritoneal metastases on cross-sectional imaging. For small lymph nodes, which are beyond the size criteria for cross-sectional imaging, and for areas of unusual metastases, which may not be routinely imaged, for example, orbital metastases or cardiac metastases. This is an example of a patient who we restaged using gallium dotatate PET-CT, as the disease was predominantly seen on somatostatin receptor imaging, this disease being a peritoneal disease. And you can see the yellow arrows point to new areas of peritoneal disease over the year that this patient, the interval between the PETs. So this patient has got progressive disease. If the patient had a CT, they may have well been called a stable disease because the disease in the peritoneum was not very well seen. So next, going on to a neuroendocrine tumor of unknown primary. So this is an example of a patient with a abdominal nodes and a biopsy proven neuroendocrine tumor from one of these nodes, but unknown primary. So we did a gallium dotatate PET CT, and you can see the nodes are intensely avid. And you can also see that there's a small focus of intense uptake within the distal duodenum, which represents the primary. And studies have shown that in approximately 50% of patients with unknown primary, gallium-68 dotatate can identify the primaries if they have a well-differentiated neuroendocrine tumor. In this particular patient, the primary was identified on cross-sectional imaging, but only on a retrospectoscope. So lastly, and importantly, gallium-68 PET can be used to identify the somatostatin receptor status. So patients can be selected for cold or radio-targeted therapy. So this concept of being selected for radio-targeted therapy using an imaging modality is called theranostics or theragnostics, where you use a molecular imaging that has similar profile to the molecular therapies, and they have the same target to identify whether or not you're going to get sufficient amount of radiation within the tumors on using a radionuclide therapy. So for this example, you can see this patient had molecular imaging with gallium-68 dotatate, and you can see this is the MIP imaging, and you can see excellent uptake with high uptake greater than that of the background liver, which is used as a surrogate to determine whether there is enough uptake in all sites of disease, particularly within the liver metastases. So this patient had progressive disease on cross-sectional imaging and went on to have treatment with lutetium dotatate. And this is a post-therapy MIP image. You can see the biodistribution is very similar to that seen on the molecular imaging. So the theranostic molecule doesn't have to be exactly the same. There's this concept of twins in spirit, where you have a similar biodistribution, but not identical. And this can help adequately predict the biodistribution of the therapeutic analog and whether or not there's going to be sufficient concentration of radiopharmaceutical within the tumors. So the molecular imaging confirms the somatostatin receptor expression, or whether or not there's enough expression, confirms biodistribution, and identifies whether there's any potential off-target effects. So when to refer patients for gallium-68 somatostatin receptor imaging in the setting of PRRT? So to recap, you need uptake greater than that of the background liver in the majority of lesions that can be resolved on the somatostatin receptor imaging used. So for PET, the resolution will be different compared to SPECT. SPECT traces can be used in the majority of low to intermediate grade neuroendocrine tumors to assess suitability. You should refer for gallium-68 PET imaging when the somatostatin receptor imaging are not positive in greater than 10% of the larger lesions that were seen on cross-sectional imaging, or at start if patients have higher grade tumors. So if they have a high G2 or G3 neuroendocrine tumor, there's a higher chance that you're going to get a negative scan using the somatostatin receptor SPECT agents. So going on to the pitfalls and artifacts of gallium-68 somatostatin receptor scintigraphy, we have both false positives and false negatives. So false positives are conditions that can overexpress somatostatin receptors as well. So these can be in the brain. We see quite commonly focus of activity representing a meningioma. And this focus is typical location for meningioma, but any focus of uptake within the brain should be confirmed on an MRI brain, as other brain pathology, for example, astrocytomas, can express somatostatin receptors. Another false positive of a patient who had a pancreatic neuroendocrine tumor and had a distal pancreatectomy and splenectomy. And this was a post-operative restaging scan. And you can see there's a focus of intense uptake of tracer in the left upper quadrant. And this focus of uptake represents accessory splenic tissue, which is quite common in the post-splenectomy scenario. If there's any doubt, consider doing a colloid scan, which would, if this was splenic tissue, it would have uptake. If it was neuroendocrine tumor, it wouldn't have uptake. So that would be able to differentiate between accessory spleen and neuroendocrine tumor. Other benign conditions, so inflammatory conditions, can also express somatostatin receptors. And this is a patient who's had a midgut neuroendocrine tumor that was excised, and this was a restaging scan, and you can see uptake within the mediastinum. And if you look at the CT, the uptake is within calcified nodes. And on looking back at previous CTs, these nodes were stable for the last 2 years. This patient has sarcoidosis. So in terms of false negatives, there are some neuroendocrine tumors that do not express significant somatostatin receptors, or you get neuroendocrine carcinomas, which are not which have higher proliferative index and less well differentiated. So this is an example of a patient with a poorly differentiated G3 neuroendocrine carcinoma. You can see the lesion was photopenic on gallium-68 dotatate imaging, while intensely FTG positive. There are some other neuroendocrine tumors that may not express a high amount of somatostatin receptors. For example, insulinomas, benign insulinomas have a lower expression of somatostatin receptors. So this is a patient with symptoms of insulinoma, and you can see a hypervascular lesion on the arterial phase CT, which is non-avid on the gallium-68 dotatate image. So combined molecular imaging using gallium-68 dotatate and FTG PET-CT is of growing interest around the world. We know that FTG PET-CT has prognostic value in all well-differentiated neuroendocrine tumors, but the particular use is in well-differentiated neuroendocrine tumors to look for tumor heterogeneity, to see if tumors are becoming de-differentiated and not expressing somatostatin receptors. And of course, up to 25% of patients with neuroendocrine tumor can have a secondary malignancy. So FTG can help to look for differential uptake within these lesions. This is an example of one of our patients with a pancreatic neuroendocrine tumor that had tumor heterogeneity. So the red arrows are somatostatin receptor expressing tumors, whilst the yellow arrows are FTG positive somatostatin receptor negative tumors. So this patient had both positive and negative tumors. Unfortunately, it was the FTG positive tumors that were progressing. So this patient has tumor heterogeneity. Okay, so in summary, gallium-68 somatostatin receptor scintigraphy is become the gold standard for staging and restaging well-differentiated neuroendocrine tumors. It is useful in about 50% of patients to identify a primary if it is unknown on cross-sectional imaging, and it is useful to select patients for radio-targeted treatment or treatment with somatostatin analogs. When reporting gallium-68 DOTA imaging, it's important to understand the pitfalls, the false negatives, false positives, and artifacts that are part and parcel of gallium-68 imaging. FTG PET-CT does have a role in neuroendocrine tumors, in high-grade tumors, to look for tumor heterogeneity and to identify patients that potentially have secondary malignancy. I'd like to thank you for your attention.